Hello everyone, my name is Lauren Heinecke. I'm an assistant professor of pharmacotherapy at the University of Maryland School of Pharmacy, and it is my pleasure to be with you today to start with the first of our series of 7 presentations on antibiotics from head to toe. Our first discussion today will be on meningitis, and specifically we'll be focusing on bacterial meningitis. So by the end of our approximately hour here together, you should be able to do the following things. You should be able to list the most common organisms seen in bacterial meningitis. You should be able to identify common signs and symptoms of bacterial meningitis. You will be able to select empiric antibiotic therapy for a patient with bacterial meningitis. We'll go through the different risk factors and age groups, which would allow you to select the best empiric antibiotic regimen. And we're going to finish up by comparing and contrasting antibiotic penetration into the central nervous system and getting into a bit of a discussion about whether to include DEXAMETHASOne as part of your empiric regimen based on the epidemiology or the etiology you think is most likely for the patient that you're treating. So in terms of the epidemiology of meningitis, I think one of the things that always helps us when we're thinking about how important an infectious disease is, and you'll notice that I have a map of Africa, which makes this seem less relevant, but this is simply because the area that meningitis, specifically meningococcal meningitis, is most common, is located across that green region in Africa, the meningitis belt. And I always find pictures are worth 1,000 words. So specifically, every year there are about 1.2 million cases of acute bacterial meningitis. This excludes epidemics. And every year around the globe, there's approximately 135,000 people that die from meningitis. Now, certainly those are not specific U.S. statistics, but I think it is important when we're thinking about antibiotics to take a bit of a global health perspective. So on the next slide, we'll get into talking a bit more about what the specific epidemiology is here in the United States, because it's changed a bit. So this particular slide shows the epidemiology and how vaccination has really changed the epidemiology of meningitis here in the United States. So let me just orient you to this graphic. What you have is the year on the x-axis. You've got 2 y-axes. So on the left-hand y-axis is the annual incidence in all ages per 100,000 population. What you have on the right-handed y-axis is the median age in years. So when we're looking at this graphic, you're going to use the left-hand y-axis when thinking about the bar graphs. And the line graph that you see, the red line, you're going to use that median age or the right-handed y-axis. And then to tell you a little bit about the color coding, because I do recognize that this might be just a little bit small in terms of the code on your screen, but Listeria, we have different pathogens represented by the color. So Listeria is gray, Strep agalactiae, or group B strep, is in the purple. Neisseria meningitis is in the reddish pink color, sort of like a salmon. Strep pneumo is in the light blue, and Haemophilus influenzae is in the green. So what you can see is that between 1986 and 2007, we have a pretty significant decrease in the overall number of cases of meningitis. Specifically, you'll notice that in between 1986 and 1995, the rate of bacterial meningitis declined by about 55% in the United States. And specifically, the reason for that decline was because of the introduction of the Haemophilus influenza type B or Hib conjugate vaccine for infants. So the other sort of interesting factor that you'll notice in between 1986 and 1995 is the median age represented by that red line significantly changed, in that meningitis really went from a disease of children to a disease of adults. You can see that in 1986, the median age was right around 1 year, whereas in 2007, the median age is, I would say, about 43 years of age. So the median age has significantly changed also as a result of vaccination. So studies that were done in the 1970s and 1980s show that there are about 5 pathogens that were responsible for more than 80% of the cases of bacterial meningitis. And those pathogens haven't changed, but the percentage of cases caused by each bacteria has changed a little bit. And again, we saw that really on the previous slide as I showed you the Haemophilus influenza previously was our most common cause with about 45%, but subsequent to vaccination that has changed. So currently, the most common cause of bacterial meningitis is strep pneumoniae with about 47%, followed by Neisseria meningitidis at about 25%. Group B strep is the next at about 13%, followed by Listeria with it accounting for about 8%. And then H flu is now down to about 7%, whereas prior to vaccination it was causing closer to 45% of the cases. So again, the availability of the vaccination for infants has significantly changed the course and the face of meningitis. Now, when we think specifically about the etiology and what specific bacteria we want to make sure we're covering for, there's a couple of different factors that we're going to take into account. So on this slide, we're going to talk about those predisposing factors and which bacterial pathogens are most likely to be causing the bacterial meningitis infection. So the predisposing factors that I have listed for you on the left-hand side really take a lot into account in terms of age, but then there's also some additional items that do come into play. So if somebody is less than 1 month of age, the most common causes are group B strep or strep agalactiae, E. coli, as well as Listeria, and Klebsiella species. When a child is between 1 and 23 months of age, the most common causes now are strep pneumoniae and Neisseria meningitidis. The same thing is true for those between the ages of 2 and 50 years of age. Now, when you get over the age of 50, or if you're a younger person who has a history of alcoholism or is immunocompromised, strep pneumo and Neisseria are still common, but now you also have to cover for Listeria and aerobic gram-negative bacilli. If there's head trauma or somebody has had a neurosurgical procedure done, strep pneumo is still common. However, now we also need to account for the fact that Staph aureus could have been introduced, and we also need to cover for aerobic gram-negative bacilli. So I think these predisposing factors really help to think about which empiric antibiotics are going to be most pertinent for your patient population. So I think that this specific table will help you significantly when thinking about what antibiotics to choose as empiric therapy for your patient. Before we get into the clinical presentation and talking a bit more about diagnosis, I thought we'd just talk very briefly about the pathophysiology. So essentially what happens in meningitis is you have nasopharyngeal colonization. That nasopharyngeal colonization leads to local invasion. Ultimately, that local invasion of the bacteria then progresses into the bloodstream and causes a bacteremia. The bacteremia then leads to meningeal invasion, and essentially this is what causes your bacterial replication in the subarachnoid space and leads to the signs and symptoms that present with meningitis. So think about the fact that there's concurrent bacteremia. That's important when we think about what specific diagnostic tests we're going to do. I think many times people obviously think about the CSF or evaluating the cerebrospinal fluid, but I think we frequently forget about the fact that we also need blood culture. So I think that thinking about the pathophysiology and remembering that there's that current bacteremia is an important piece of thinking about a patient with meningitis. In terms of the clinical presentation, many people are probably very familiar with these signs and symptoms. And just to give you a quick definition, acute meningitis is actually defined as a syndrome that's characterized by the onset of meningeal symptoms, the symptoms that I have listed here for you on the slide, really over hours to several days. And so the typical signs and symptoms that you'll see are fever, as well as nuchal rigidity or neck rigidity, altered mental status, as well as headache and chills. People also can complain of photophobia. Essentially, the light will make things worse for them in terms of headache and other symptoms. They may vomit. Pretty progressive disease can lead to seizures, and then Koenig's and Brudzinski signs can be common as well. In terms of thinking about which symptoms are early versus late, headache is typically an early symptom, whereas altered mental status or a coma are typically seen as the disease has been present for a little bit of time, just to sort of give you an idea which things you might see earlier on in the disease course and which things you might see a bit later on as the disease progresses or has been present for a longer period of time. And so I practice in the adult population, but I do think it's an important thing to give you a bit of an insight into how neonates might present, because certainly they're not able to tell you a bit more about, yes, I've got some neck rigidity or I've got a headache. So some of the things that you can look for in terms of neonates is they've got really temperature instability. They also may be lethargic. They might have a high-pitched cry, refusal to feed, or a weak suck. And they might be very irritable. So I think it's important to have sort of a good inkling as to what to expect in a neonate as well, if this is a population that you're practicing in, because certainly these are a bit more difficult to identify, as the neonate isn't able to give you some of the additional information. At this point, we're going to get into talking a little bit about diagnosis. Now that we have a good understanding of the particular organisms that patients are at risk for, and we have an idea about how they might present when we see them in their PCP's office or in the emergency room. So in terms of diagnosis, we've already talked about how important blood cultures are, but we also want to perform a lumbar puncture and evaluate the cerebrospinal fluid. So I have a table set up for you which shows you the various causes of meningitis, viral and bacterial, and then what you would expect to see in a normal CSF fluid evaluation. So the three important things to take into account are white blood cells, which makes sense. If there's an infection present, you would expect for this to be high. You want to also take into account the glucose concentration as well as the protein concentration. And I think the way that I've always sort of made sense of this, and this might sound a bit simplistic to you, is that in a patient who has bacterial meningitis, that bacteria needs some sort of food source. You would expect for the glucose to go down in a bacterial meningitis infection. And then the protein you would expect to go up in a bacterial meningitis infection, because bacteria themselves are proteins, right? So I think the numbers are important, but one of the more simple ways to sort of think about this is just thinking through what the bacteria you would expect them to do and what you would expect to see in terms of whether those counts would go up or down. So we'll talk specifically about the numbers. So looking at the white blood cell count by the cause of meningitis. So normal is less than 5 cells per millimeter cubed. Viral meningitis, you do have an increase in the white blood cell count, but it's not nearly as great of an increase as what you see with bacterial meningitis. So generally with viral meningitis, you have a white blood cell count of between 50 and 1,000 cells per millimeter cubed. And then finally with bacterial meningitis, generally it's a much higher number, between 1,000 and 5,000 cells per millimeter cubed. In terms of glucose, this is in milligrams per deciliter. The important thing when you're considering the glucose is it really should be compared with a simultaneous serum glucose. And so the numbers that I have reported up there for you are the actual number with viral and bacterial, but I'll also tell you essentially what you should look for in terms of the ratio. So normal is about 50 to 66% of the simultaneous glucose value. So let's say you have a patient who has a blood glucose value of 120, which is, relatively normal for a fasting blood glucose. You would expect that the normal in a CSF evaluation would be right around 60 to make the math easy for myself. Now, if it's a viral infection, it's generally less than what you would see in normal, but more than what you would see in a bacterial infection, so generally greater than 45 milligrams per deciliter. In bacterial, as I've already mentioned in my quick overview about how to simplistically think about the CSF evaluation, the glucose would be less than 40 milligrams per deciliter. Now, if you're thinking about the ratio of the glucose in the CSF to the serum glucose, generally it should be anything less than 0.5 is considered abnormal, and really diagnostic would be less than or equal to 0.4. So which sort of makes some sense in terms of that 40 milligrams per deciliter if you're thinking about 100 being a relatively normal blood sugar level. So if you're looking at the ratio, think about less than or equal to 0.4 as being really pretty diagnostic of meningitis, but anything that's less than 0.5 is considered abnormal. Now, in terms of protein, normal is less than 50. In viral, you have an elevation in your protein, but not to the same magnitude as seen in bacterial meningitis, so it should be less than 200, but likely greater than 50. And then in bacterial meningitis, we're going to see a bit of an overlap between viral and bacterial. Generally, bacterial will be a higher protein load in the CSF, between 100 and 500 milligrams per deciliter. Now, one of the things that we can do is to perform a gram stain. I'll talk about that a bit more in detail. And one of the things that is problematic with the gram stain is that certainly our yield can be decreased if somebody has received prior antibiotic therapy, but we'll talk about that in just one slide or two. So we will discuss the gram stain in greater detail. Before we move on to talking about gram stains and some additional testing that can be done, depending on your specific patient, is it's important to account for your white blood cell count if you have a traumatic LP. And essentially what that means is that there's a lot of blood in the lumbar puncture. And when you have an elevated red blood cell count or a traumatic tap, the white blood cell count can be off, essentially. And so to calculate the true white blood cell count in the CSF is to take the actual white blood cell count that's been reported, subtract the white blood cells that are in the blood, multiply this by the red blood cells in the CSF, and then divide by the red blood cells in the blood. So this equation will allow you to account for the traumatic LP and give you an actual count for your WBCs in your CSF during a traumatic tap. The protein, interestingly, or it makes sense, could also be elevated in patients with a traumatic LP. So to correct this, you subtract 1 milligram per deciliter of protein for every 1,000 red blood cells per millimeter cubed that's seen. So you want to correct the white blood cell count as well as the protein in a patient who has a traumatic lumbar puncture to get a more accurate sense of the actual counts. And as promised, we're going to talk a bit more about the gram stain. The gram stain is probably the most helpful of the additional tests that you can do. It's a rapid and accurate identification of organisms in about 60 to 90% of patients who have community-acquired meningitis. The gram stain does correlate with the CSF concentration of bacteria. So if you have a smaller or lower concentration of bacteria, you might have a lesser chance of having a positive gram stain. The important thing to recognize is that the sensitivity is decreased to 40 to 60% in patients who have received antibiotic therapy. So the gram stain is less helpful in patients who have had their LP done after receiving antibiotic therapy. That's not to say that you delay antibiotic therapy until you can get your LP. It's just important when you're thinking about how to progress with the clinical course, depending on what your gram stain shows or doesn't show. There was actually a pretty interesting study done in infants and children with bacterial meningitis. And in this particular study, they found that the initial positive CSF culture became sterile in closer to 90 to 100% of patients within 24 to 36 hours of antibiotic therapy. So again, if somebody has received antibiotic therapy before the LP can be done, this does change how we think about what to do with our antibiotic therapy. I think we're using a lot more of the whole picture of the patient, their clinical presentation, and how likely we think meningitis is in terms of deciding if we can discontinue therapy versus narrowing therapy and continuing empiric therapy. In addition to the gram stain, there are some additional tests that can be done. These include a PCR as well as latex agglutination, and this is some specific tests that's done on the CSF fluid cultures. The PCR test may be helpful, but is a relatively expensive test and isn't available at all institutions. Latex agglutination is also potentially a helpful test. It's specific for different organisms, but there have been some issues with both of these specific tests. So I would recommend just seeing what your specific institution does, and I would say that these two tests are not routinely done, but would be interested to know what your respective institutions do if anyone wants to provide a comment or additional thoughts during the question and answer period. In terms of imaging, there are two imaging techniques that can be done, and those are the head CT as well as the brain MRI. The indication for getting these two items are in patients who have a new onset seizure. And this is really to make sure that there's no sort of mass that would compromise doing your LP. So certainly someone with a mass, there's greater risk when doing a lumbar puncture. So these are really new onset seizure is the indication for doing one of these two imaging modalities. Again, as I mentioned before with the gram stain, so giving antibiotic therapy prior to doing an LP definitely can affect your results of your gram stain, but you should not delay antibiotic therapy because the LP can't be performed right away. I know specifically at our institution, sometimes we have patients who are difficult to get an LP on. We never delay therapy. Now that does play into our decision to continue or discontinue therapy or narrow therapy, but you would not want to delay therapy if the LP can't be done right away. So now we've got our basic information down and we understand how much the face of meningitis has really changed in the last about 15 years. And so we're going to get into talking about treatment and how we select our empiric antibiotics. So this next table is going to look relatively similar to our epidemiology by pathogens and by predisposing factor, but now we have an additional column on the far right-hand side, which is our empiric antimicrobial therapy. And so essentially we have our predisposing factors in the left-hand column, followed by our bacterial pathogens, which we've already talked about in the beginning part of this presentation, and then our empiric antimicrobial therapy, which should make sense thinking about our bacterial pathogens. So in our neonates who are less than 1 month of age, our pathogens are, as we've discussed before, and our empiric therapy is going to be ampicillin plus cefotaxime. In our children who are between the age of 1 and 23 months, again, we've talked about our pathogens, and the same is true for between the ages of 2 and 50, same pathogens. And then our treatment options are going to be the same for these groups, cefotaxime or ceftriaxone, so a third-generation cephalosporin, plus vancomycin, and the vancomycin is really to hit the resistant strep pneumo strains, and then plus or minus dexamethasone. And we'll talk a little bit more about the dexamethasone debate in just a few slides. I thought that deserved its own time for discussion. People over the age of 50 or are alcoholics or are immunocompromised, again, we have some additional pathogens. So we're going to add the ampicillin back in. The ampicillin is what gives us our listeria coverage. Our cefotaxime or ceftriaxone, our third-generation cephalosporins, are going to cover our strep pneumo, Neisseria meningitis, and our aerobic gram-negative bacilli. And then our vancomycin, again, covers for our resistant strep pneumo bugs. And then finally, our last group is our folks that have had a head trauma or have had a neurosurgical procedure. And so these folks, again, have the Staph aureus now introduced as a potential risk. And so for these people, we're going to use vancomycin plus cefepime or ceftazidime. And because these folks are hospitalized, cefepime and ceftazidime, we're going for a bit of a broader gram-negative coverage. And our vancomycin, again, will cover resistant strep pneumo and if the patient is infected with a MRSA strain. One of the things that I thought was interesting to just introduce as part of this talk is relative to the timing of antimicrobial administration, whether that's been linked to clinical outcomes with bacterial meningitis. And we don't actually have any prospective clinical data on the relationship of the time that the antimicrobial is given relative to the clinical outcome of patients. But, just I think what I think most pharmacists and physicians would agree with is that the longer the duration of symptoms, the more likely the patient is to experience an adverse outcome. So again, this really just gets back to the fact that we don't want to delay antibiotic therapy in patients. Certainly if we can get the LP prior to starting antibiotic therapy, that would be additional or ideal, but we certainly are not going to delay our antibiotic therapy because we're unable to get an LP. Hopefully this table will help you walk through your predisposing factor, the bacterial pathogens that are most likely in your patient population, and then specifically what medications to choose and what those medications specifically will cover. So now that we've gone through our empiric antibiotics, I want to just take a minute to answer the question, what if my patient has a penicillin allergy? Because you'll notice up there we have a lot of use of our third generation cephalosporins. And so I think the important thing as a pharmacist is that it's important to think about the type of allergy that a patient is reporting with penicillin, and then to think about what the cross-reactivity is with the cephalosporin. So cross-reactivity with cephalosporins and penicillins has been, I think, a widely debated topic, and really if you take a look at the literature, you can find reports of anywhere, I would say, between 1 and 10%. And many people would agree that the risk of cross-reactivity is relatively low. That being said, if someone has a very serious anaphylactic reaction, you may choose to desensitize them to the cephalosporin, or if they have an allergy to a cephalosporin, certainly desensitization would be an important thing to do. The nice option is that for your strep pneumo, you're including vancomycin for your resistant. So you're already covering strep pneumo by keeping that vancomycin on. And certainly vancomycin is a nice option in patients who have a penicillin or a cephalosporin allergy. In terms of covering your Neisseria meningitidis, the recommendation is really to include a fluoroquinolone. And then if you have a patient population where you're concerned about listeria, the medication of choice for listeria in a penicillin allergic patient is going to be Bactrim or trimethoprim sulfamethoxazole. And then certainly in patients where you're concerned about aerobic gram-negative bacilli, again, your fluoroquinolone is likely to cover what you need it to cover. So I just wanted to take a couple of quick minutes to talk through what we can do if we have a penicillin allergy. And certainly if we need to initiate one of those alternative agents, it is possible to desensitize patients and to use a cephalosporin or a penicillin if absolutely necessary. At this point in the presentation, I think it's appropriate to talk a little bit about antibiotic penetration. And I think it's appropriate to talk about antibiotic penetration just before we get into our discussion about whether or not dexamethasone is appropriate in any patients. So before we can really get into talking about antibiotic penetration, we need a quick anatomy and physiology review. So it's important to remember that there are natural barriers to the exchange of medications between the blood and the brain and the CSF. So we have the blood-brain barrier and the blood-CSF barrier. So taking a look at this picture up here, this really only demonstrates the blood-brain barrier. The blood-brain barrier is made up of the tightly joined capillary endothelial cells, which you see represented there right below the tight junctions. And so drug entry into the brain tissue is accomplished via direct passage through the capillary endothelial cells and then further penetration of the glial cells. So in order for a medication then to get into the cerebrospinal fluid or the CSF, this is controlled by the blood-CSF barrier. So the barrier that makes up the barrier between the blood and the cerebrospinal fluid is created by special cells called ependymal cells that make up the choroid plexus. And so the inflammatory process that happens along with meningitis actually allows better penetration of medications through the choroid plexus. It actually inhibits the active transport system of the choroid plexus. So inflammation actually is beneficial from an anatomy and physiology standpoint in terms of getting greater drug concentrations into the areas that we need to in terms of being able to treat the meningitis. So keep that in mind on the next couple of slides and then as we get into our dexamethasone discussion. So there was some really nice tables that were actually published as part of the meningitis chapter in the pharmacotherapy book. And so they have the medications broken down by antibiotics that are able to penetrate into the CNS with or without inflammation, and then those that have significantly better penetration if inflammation is present. And so before we get into specifically talking about the medications, and you can see the ones that really penetrate with and without inflammation up there on the slide, but I think it's important to think about specific drug characteristics that make them better at penetrating into the brain and then into the central nervous system. So a couple of important characteristics of medications. Antibiotics that have lower molecular weights are passed more easily through the blood-brain barrier. Also, non-ionized medications are highly capable of diffusion, making it much easier for them to cross into the blood-brain barrier. Things that are more lipid-soluble penetrate much better than things that are water-soluble. And then antibiotics that are not extensively protein-bound or have a larger free fraction allows a larger amount of the drug that's able to pass into the central nervous system and the cerebrospinal fluid. So a couple of characteristics that really, if you don't have some good studies, if you're looking for something alternative to use in a central nervous system infection, those are some characteristics of medications that you might want to consider. Okay, so getting back to some of the easier concepts, really just some quick lists you could potentially memorize. So these are the antibiotics that really are able to penetrate into the central nervous system with or without inflammation. It doesn't really make a lot of difference. So chloramphenicol, cycloserine, ethonamide, isoniazid, metronidazole, pyrazinamide, rifampin, bisulfonamides, and trimethoprim. So not a very big list, and you'll notice that none of those medications were included in our empiric antibiotic table. So here is your long list of medications that you achieve therapeutic concentrations with inflammation. So inflammation might actually be beneficial in terms of allowing these medications to cross the blood-brain barrier. You'll notice that many of our medications, which we talked about as empiric therapy, including ceftriaxone, cefotaxime, as well as vancomycin, are all up there, as well as ampicillin. So many of our first-line agents were actually, we would get better concentrations by having inflammation present. So I don't want to get a lot more into specific antibiotic penetration. I think having a general sense that our antibiotics that we use, we get better concentrations and higher concentrations in the presence of inflammation is enough for our conversations today. That brings us into really one of our last big topics for conversation, and that's dexamethasone. So the question is, should we be using dexamethasone or should we not be using dexamethasone? Are there particular populations who might benefit more from dexamethasone? And so essentially the crux of this is that there are certain patients that may benefit. And the rationale behind this is that the subarachnoid space, there's an inflammatory response that occurs during bacterial meningitis. And specifically, looking at this in animal models, it contributes to morbidity and mortality. So the thought is that by decreasing this inflammation, we can decrease cerebral edema, increased intracranial pressure, altered cerebral blood flow, cerebral vasculitis, and neuronal injury. So a lot of the different pathophysiology mechanisms behind what meningitis actually does within the CNS, and maybe by altering these things, maybe we could decrease the morbidity and mortality associated with meningitis. So now the question is, should we be using dexamethasone? And I think the best way to take a look at this is by breaking it down by population. So I've put neonates, infants, and children all together, and then I have a second slide about adults. So, and I have to say, the neonates have really not been studied very well, so this is really more applying to infants and children. This recommendation specifically comes from the American Academy of Pediatrics. So the recommendations are that dexamethasone should be considered for infants and children over 2 months of age with pneumococcal meningitis, and that it should be given at a dose of 0.15 milligrams per kilo every 6 hours for 2 days to infants and children over 2 months of age with H. influenza meningitis. So 2 things with respect to these 2 comments. So we know that the incidence of H. influenza meningitis is relatively low given the advent of the vaccine. So we're not going to see a lot of H. influenza meningitis. The second thing is in terms of the pneumococcal meningitis. So the time frame in which dexamethasone was studied in children with pneumococcal meningitis was before we were seeing a lot of resistant strep pneumo. So I think there's some question as to whether or not the dexamethasone would still be beneficial in kids who are infected with resistant strep pneumo meningitis. So, and then I think the other big point to remember is that in these studies, the big outcome that they saw dexamethasone improve was a decrease in hearing loss associated with meningitis. So we're not talking about a decrease in mortality associated with meningitis. And so I think, again, going back to our conversation about inflammation and antibiotic penetration, I think for myself, I would be hard-pressed to add dexamethasone when I'm not showing a decreased mortality. We certainly know that not adequately treating the infection via appropriate concentration certainly is more likely to lead to treatment failure and mortality. So the last piece of this is if you are going to be using dexamethasone, it should be given prior to the initiation of antibiotics. It can be given along with the first dose or, within a half an hour of the first dose, but really before. And after antibiotic therapy has been started, it has not been shown to be beneficial. So then what's the data in adults? So the data in adults, I would say, is maybe slightly stronger. It makes me want to use dexamethasone a bit more. Specifically, the Infectious Disease Society of America recommends using dexamethasone at 0.15 milligrams per kilo every 6 hours for 2 to 4 days in adults with suspected or proven pneumococcal meningitis. So it has been shown to decrease mortality in adults with pneumococcal meningitis. The steroid therapy really should begin within 10 to 20 minutes prior to starting antibiotics, and you would not want to initiate dexamethasone therapy in an adult who has already received antibiotics. So I think there is potentially a role for dexamethasone in pneumococcal meningitis in adults, but I would say that's probably the area where the data is the strongest. And in my particular practice, generally when I come in the morning, they've suspected someone of having meningitis, and they've already given the antibiotics before I've ever even seen the patient. And so frequently there hasn't been a discussion of using dexamethasone. So I don't frequently see dexamethasone used as part of my routine practice when we have someone come in and there's an empiric concern about meningitis. So we'll wrap up the rest of our conversation with 4 slides, just looking specifically at antibiotics by pathogen. So we are able to narrow our therapy when we have some additional information about the microorganism as well as some susceptibility data. And so I've got this broken down into 2 tables, hopefully to allow for larger font, and hopefully everybody's able to see this when they print out the slide set. So the microorganism and the susceptibility is in your far left-hand column, standard therapy is in the center column, and then the alternative therapies are in your far right-hand column. So looking at strep pneumo, knowing the minimum inhibitory concentration, or MIC, is very important in terms of deciding which therapy you're able to use. And then also taking a look at ceftriaxone or cefotaxime MICs in terms of determining whether or not vancomycin would need to be added to your 3rd generation cephalosporin. So really we can use penicillin G or ampicillin if we have a highly susceptible isolate, a 3rd generation cephalosporin if we've got sort of intermediate susceptibility. Then if we've got a relatively resistant bug, we're looking at using vancomycin in addition to a 3rd generation cephalosporin. In Neisseria meningitidis, again, our minimum inhibitory concentration is going to make a difference. If we're looking at a very susceptible organism, it's going to be either penicillin G or ampicillin again. If we're looking at a higher MIC, it's going to be a 3rd generation cephalosporin. With Listeria and group B strep, ampicillin or penicillin G are generally our treatments of choice. Okay, so going over just a few more bugs. So E. coli and other Enterobacteriaceae, a 3rd generation cephalosporin generally is going to be our drug of choice. Pseudomonas, we tend to use cefepime or ceftazidime, our 3rd generation cephalosporin with Pseudomonas coverage, and then our 4th generation cephalosporin. For H. flu, it depends if we've got a beta-lactamase negative or positive organism. If it's a beta-lactamase negative, we can do ampicillin. If it's beta-lactamase positive, we're looking at a 3rd generation cephalosporin. In terms of Staph aureus, of course, it matters if it's MSSA or MRSA in terms of whether we would be able to use nafcillin or oxacillin, or if we would need to go ahead and use something like vancomycin. For Staph epidermidis, vancomycin is our therapy of choice. And then for Enterococcus, again, it depends on our susceptibility data, whether we can use ampicillin plus gent, vanc plus gent, or linezolid. And again, a lot of this is just dependent on our susceptibility data. So we can narrow as we get additional data back, and depending on whether the person got antibiotic therapy prior to getting their lumbar puncture. The next question after we've narrowed our antibiotic, if we can, by our pathogen is how long are we going to be treating these folks for? So our duration of therapy really depends on the microorganism that's causing the disease. So if we're looking at Neisseria meningitidis or Haemophilus influenza, we're looking at a duration of about 7 days. If we're looking at strep pneumo, we're talking about 10 to 14 days. Group B strep, we're looking at a bit of a longer duration, 14 to 21 days. Aerobic gram-negative bacilli, we go a little bit longer to 21 days. And then Listeria, we're going for at least 21 days, potentially longer than that, depending on how the person responds. So knowing our microorganism really helps us determine the length of time that someone is going to need to be treated with antibiotics. And then I think I would be remiss if I didn't finish up by talking about prevention. And so I didn't go into prevention with vaccination, but prevention with vaccination is a huge part of this as well. But I think that's better served for another place and time. I think just talking a very brief amount about chemoprophylaxis in terms of if you have someone who's exposed to a patient who is found to have meningitis with one of these causative organisms, is there any recommendation in terms of giving them specific therapy? And so the recommendations that have come out from IDSA and others are really around being able to eliminate any nasopharyngeal colonization. And so this would be more important if you have younger children who are not vaccinated or not fully vaccinated against Haemophilus influenza. So Haemophilus influenza, there are recommendations to treat close contacts with rifampin 20 mg per kg every day for 4 days. For Neisseria meningitidis, there are recommendations again for close contacts. There's a few different options. You can use rifampin or ceftriaxone or ciprofloxacin if we're just talking about an adult. For strep pneumo, there is no chemoprophylaxis that is recommended. And for group B strep, we're talking about prophylaxis really at the time that a mother would deliver. So at the time of delivery, they would be given ampicillin 2 grams IV every 4 hours. So potentially close contacts with Haemophilus influenza or Neisseria meningitidis, we would use chemoprophylaxis in those particular patients.